It is a huge honor for me today to be podcast interviewing my buddy Stephen Feit. How are you doing?
Great, Howard.
Who just flew in today from Boca Raton, Florida. And I've always told everybody that when you read all 4 million posts on Dentaltown, like practically I have since 1998, dentists agree on a lot of stuff. But the most controversial thing has got to be occlusion. And when you told me that you figured it out, I said, okay, we're doing a podcast. Do you agree or disagree that occlusion is, there's so many occlusal camps? I mean, there's Dawson, there's Pankey, there's Coy, Spear, LVI, neuromuscular, and podcasters are usually under 30. And the first question that they're actually asking on occlusion is, do I go down the CR Pinky Dawson path? Do I go down the neuromuscular path? Why is this so controversial?
Well,
and before I got to read your bio because they wouldn't even know you. Well, you're basically a dentist and a prosthodontist. So this isn't So Stephen trained in dentistry by having completed an accelerated combined 7-year program at Muhlenberg College, Allentown, Pennsylvania, and the University of Medicine and Dentistry of New Jersey Dental School. He went on to complete his advanced specialty training in prosthodontics at the Goldman School of Graduate Dentistry, Boston University. Stephen was born in New York City and raised the oldest of 4 children in Oradell, New Jersey, near the George Washington Bridge. He enjoys spending time with his wife, Traci, their kids. His hobbies include teaching and coaching the kids athletic, fitness, restoring old classic cars. So you must have a little Jay Leno in your blood there somewhere. Stephen conducted cancer research at Columbia Presbyterian Medical Center in New York City. And while at University of Medical Dental School, New Jersey, Stephen has been honored with faculty appointments as assistant clinical professor at New Jersey Dental School, clinical teaching fellow at Boston University, and clinical attending at Monmouth Medical Center in Long Branch, New Jersey. You have had an extremely distinguished career. So why did you get interested in occlusion, and how the heck did you figure it out?
Well, Howard, it's a great question. First off, if you were to meet me at a party and say, what do I do for a living? I'll tell you that I'm a stress manager, right? Everything we introduce in the oral cavity has to exceed the stresses that are delivered to it. That's a given. The question is, how long can you get something to exceed the stresses? That equals so-called success. If you don't do it for a long time, the patient deems it a failure, and that's their reality. So how do we achieve it? In my dental training, as with yours and anybody else's, occlusion was glossed over at best. Get everything as even as possible, and that was about the whole thing of occlusion. So then there's as you mentioned, Pankey Man, Schuyler were in the 40s. Dawson was a disciple of them, and then he took the baton and carried it forward. Spears and Coyce took the baton from Dawson, expanded on things, and did their own. Then you have neuromuscular. That was technology back in the 40s that kind of died away and then was revitalized. And then I'm sure there's other things. I heard about the tech scan. One of my professors, Bill Manis, was the one who invented it. So I'm intimately aware of the T scan. Me and Bill Lopez, who is a anatomist and dental laboratory technician as well, we've been researching this whole issue. If occlusion is in fact the basis of all success of what we do, and there is so much controversy, there's no mystery why there's so many attorneys making a very fine living doing dental malpractice. I have been an expert witness for about 15 years. I've probably been involved with over 150 cases, which really sets me apart because that's a lot of cases. I am 18 for 18 of the last 18 board complaints against dentists. I only represent dentists. But when adverse counsel asks me why I don't do any plaintiff work, the answer is very simple. If I receive a case and it's well below the standard of care, it's absolutely indefensible, then I advise the attorney as such and tell him to settle the case. But if we can defend it, and usually it is defensible, usually it's relationship breakdown. It's the subsequent treater has a big mouth and is looking that the patient should get money back from the previous treater, in order to pay their way. Of course, that's a whole nother podcast. But as far as occlusion goes, Needles, back in, I think in the 90s, he wrote an article, and one of the quotes in his article off the top of my head is, "Physics exists in the mouth." And I've listened to a lot of your podcasts, and we hear about TMD, TMJ, the confusion. You point that out. We hear about confusion about how to set things up, how to do it. Well, if there's no consensus on it, it's wide open to litigation, in my opinion. So when I say we figured it out, you mentioned I did cancer research, which I did, and that led me away from medicine. And anyway, the research has trained my mind in that we didn't want to bring this out to the profession prematurely. We didn't want anything to be incorrect. We wanted to hone it, tweak it, and have a chunk of time behind us. Usually 20 years is a valid study. So what we evaluated was we discovered relationships. Okay, now you can't patent a relationship. So if I took a pen and I held it 3 feet above the table and let go of it, it would fall. And what we would discover is gravity. Can we patent that? No, we can't patent it because we didn't create it, but we did discover it. Someone did discover it. Okay, so we discovered that there's leverages in the mouth if I use the analogy of a scissor. So if I'm speaking with a patient, and I know a lot of the dentists are fresh out of school maybe or is still in school, and I really respect that for someone looking for continuing education while they're getting the mediocrity training called dental school, because we all know in retrospect how deficient that really is. So so what we discovered was that I'll get right into it, and just interrupt me if
you're like listening to Beethoven on the piano.
Okay, so if we were, and I know people are driving maybe on their way to work or wherever they are, and they're doing this. So I'm going to be as visual as I can, since I don't have a PowerPoint to bring it home, which would do so in very short time.
We can only do iTunes because I have a face for radio,
yes,
not
right.
TV, so
yeah.
I couldn't.
Well, my face is like yours. So anyway, if you took retromolar pads, that's the first Dentures 101 freshman first semester, right? The basic course, and we want to set the plane of occlusion. They're very clear to use retromolar pad, and Spee was the one who did that in the 1890s. And Spee was what they call an anatomist, but he wasn't. He was really actually a dental technician. But how can
Curvis Spee was a dental technician?
Yeah. So how could a dentist take the lead from a dental technician? So if you ask me, do I dictate to my laboratory? Does the laboratory dictate to me? A very simple answer. The laboratory dictates to me all day, every day, all the time, every procedure. Because if I'm doing a crown, for a simple example, and I don't reduce the tooth enough for the amount of material that's necessary, whether it's zirconia, porcelain fused to metal, whatever restoration of choice, the lab's going to ask me the question, do you want a reduction coping, or do you want to reduce the opposing tooth? Now, through this discussion, you'll see why it's absolutely detrimental to adjust the opposing tooth, and I'll explain why, because it has to relate to leverages. So this is easily a 3 or 4 day course, but we're gonna just fillet it out, make it real simple.
Well, you should make that course on the online Dental Town.
We're in the works with that, actually, as we speak.
Awesome.
This is all pending publication, so we didn't want to bring this out because this is very, very interesting material, very unique. I've done an exhaustive literature review, and there's nothing even close to this anywhere in the literature. So if we were to say, okay, we use retromolar pads. All right, so we want to set the occlusal table to retromolar pads. Well, you have a retromolar pad on the right side and one on the left. We have a right eye and a left eye. So if I showed you an image with a half a head and I asked you, where do you think the left eye would be if you knew where the right eye is, you'd have a fighting chance and say, look, barring any syndrome or some major trauma, it should be about symmetrically located on the other side. Same with the ears, so on. So we could say that the retromolar pad on the right side and the left side are about the same. If you drew a horizontal line, it would be, that line would be fairly, say, straight. Some of the pads are short and squat, some are long and narrow, some are medium, some fall in a little bit to the lingual, some are right in the middle. there is a learning curve to recognize retromolar pad. If you drew a line through the condyles, if you had, say, the mandible was extracted from the skull, and you drew a line right through the poles of the mandible, of the condyles, you would find that that line through the condyles is parallel to the line of the retromolar pad. If you drew a perpendicular based on geometric principles, and this is in the article, by definition, with the two lines that are never going to intersect, that are parallel, there's a finite relationship between those two lines. So in fact, when you look in the oral cavity and you see the imaginary line between the retromolar pad, you're actually looking at hinge axis. That's wow. Okay, so we're looking at hinge axis. So what do we do with that information? Well, if the whole goal is to put the models on an articulator of whatever articulator system you want, it doesn't matter. You could take a hinge off the door. It needs to be on hinge axis. And if it's not, you're going to spend your entire career grinding it in. And I don't know about you, early in my career, before we were privy to this information, sometimes patients would actually look up and say, "Are you sure that that's my crown? Because you're grinding so much, right? Because there's inherent errors in processing. Maybe the model expanded or the impression warped or what have you." Okay, so we know that the retromolar pads are useful. Well, in order to create a plane, we need a third point. Well, in dental school, they never talk about a third point. So we created the third point through an exhaustive study. And what we noted was when a patient goes into high smile, whether they have teeth or they're completely edentulous in both arches, one arch or the other, this is it's not a symmetric smile analysis as if you're doing it for the AACD or looking to do veneers or a cosmetic situation. This is one point, generally between the two central incisors in the maxillary arch. The patient smiles as wide as they can. And what happens is you measure from the inferior border of the upper lip 6 millimeters to 9 millimeters below. That's where the most aesthetic, most pleasing incisal edge position is going to be.
6 to 9 millimeters?
6 to 9 millimeters.
On high smile.
On high smile, right. Now you take that point, combine with the 2 points of retromolar pad, and you mount the mandibular model first on the articulator. So everyone's going to say, how do you do that? Well, you could take the tricks that we use are we take a chunk of plaster, and instead of using clear water to mix the plaster to mount the model, you take the plaster on a grinder and take the slurry out, and then what happens is the plaster sets incredibly fast. So you can then mount the mandibular model, and then the maxillary model is mounted to that, because retromolar pads relate to hinge axis. That's the only anatomical relationship to hinge axis that we can utilize in a dental world. So when the assistant, we call it care nurse, when they do the impressions, they have to capture the retromolar pad bilaterally, we have to pour it bilaterally, and we must not trim it off bilaterally. And why do we trim it off? Because the models fit neatly in the box to ship to the laboratory. Okay, so now we have the models mounted, right? We have it what we call orientation. So we call it the 7 ions. So the first ion is impression, because it ends in ION, impression. So you impression the anatomical entities. The second ion would then be orientation. And then from orientation, we can now do evaluation. So what do we evaluate? We evaluate the plane of occlusion. Let's say the patient was missing the maxillary left side for a period of time. And let's say they were missing tooth number 15 and tooth number 19, or tooth number 14, and tooth number 19 super erupted into that edentulous space. Okay, what happens? Remember from chemistry, Le Chatelier, he had a principle. Le Chatelier said that if you place a stress on the system's going to react to relieve the stress. It's all the time, every time. It's a principle, just like gravity with dropping the pencil. So if the tooth is super erupted and you build a new tooth above opposing it in the number 14 position, and you don't adjust the super erupted 19, what happens? So let's talk about leverage. If you had a scissor and asked a little kid in kindergarten to cut a thick piece of cardboard, they'd open their little fingers as wide as they could and get the cardboard as close to the hinge as possible to get a fighting chance to cut it. And that's called leverage. But they don't know leverage, they just know it works. So if we look at the oral cavity, where do we choose? So now we have the 3 steps to function. So you're old enough, because you're my age. The Honeymooners, remember the $64,000 question? And he knew every single song except the warm-up song that Ed Norton would play, which was Swanee River. So if you said to any dentist who hasn't heard this yet, what are the 3 steps to function? Well, they look at you and they don't know. So you mentioned I restore old cars. So I'm into mechanics. I understand mechanics, I understand leverages. I understand that I could wrap 2 wrenches together, make a longer lever arm, and I can undo a bolt that may be rusted, locked, because I have a longer leverage arm by putting 2 wrenches together. Okay, so if we look in the mouth, the first step is you incise. You take a bite of the apple, right? How do you do that? With the incisors. Okay, so now, do we chew on the incisors? No, there's no musculature in the incisor area. You just don't have any power closing muscles. What are the closing muscles? Is the masseter, the temporalis. Where is that? That's located in the back. Okay, so then there's 3 steps. So if the first step is incise, how do you get to mastication? How do you actually chew and crush and mill the food? Well, there's something in there that is 4 muscles. It's called the tongue. The tongue pulls the food to the active zone. Dawson calls it the neutral zone. But I don't disagree. It's a matter of perspective. But you have musculature on the buccal of each posterior segment. And you have muscle on the lingual of each posterior segment. And the 2 muscles working in conjunction in order to keep the food in the active zone. I call the active zone. Dawson refers as a neutral zone. It doesn't matter what you call it as long as you know that it's on the teeth and that they're chewing. Now, how do we chew? The cusps are buccal and lingual, not mesial and distal. So you can't chew front to back. It's just not, if you try to do it, it's just not a possible thing. So we all know from the multicolored wax up when we did it in dental school and you had to do the cusp tips and all that kind of stuff, the occlusal table of the molars are 5 millimeters wide. The height of contour may be significantly wider than a premolar, for sure. And the CEJ is wider, but the actual occlusal table is 5 millimeters. The premolars are also 5 millimeters. So the occlusal table, if you drew a line of all the cusp tips, we call it the BOL, the buccal occlusal line, is on the mandibular left arch would be all the buccal cusps of teeth 18, 19, 20, 21. And then you have the lingual occlusal line, and then you have the central fossa occlusal line. So in an ideal setting, class 1 relationship, you're going to have the palatal occlusal line of the opposing upper fall into the central fossa line of the lower. Okay, so let's take the example. So we chew laterally, and we say how far does the mandible have to traverse in order to masticate in the active or neutral zone? And the answer would be if the occlusal table is 5 millimeters, you go 2.5 millimeters to one side and 2.5 to the other. Because if you go further than that, the teeth won't oppose each other. So now we understand how the system actually functions. Pankey and Dawson always said, how dare you try to fix something if you don't know how it works? Can you imagine a mechanic doesn't understand what a 4-stroke motor is? How do you fix the motor? When a lawnmower is a 2-stroke motor, it's a different apparatus. So you're going to need to understand the differences in those 2 machines. So the typical dentist doesn't even understand the 3 steps to function. So can you imagine in court when the expert witness who's trying to go for the plaintiff against our colleague in dentistry, and I provide the attorney with the questions, I slide it across, I say, ask him the 3 steps of function. Ask him how many steps there are in functioning, ask what the 3 steps are. And some of these experts get disqualified. They'll never be an expert again because they couldn't answer a simple question. How could you be an expert in the eyes of the court? You're wasting the court's time. So it makes it very powerful. Okay, so now let's get back to the scenario.
So summarize again, what were the 3 steps?
Okay, the 3 steps are incising. The tongue pulls the food back to the posterior
Is number
area.
2.
Number 2
Is tongue.
is tongue, and number 3 is actually chewing up and down with the molars, premolars, and you chew side to side. We call it lateral.
Okay.
Then you swallow.
And what were the 7 ions?
Okay, we'll get to the 7
Well, okay.
ions. Yeah, I'll finish with that, and then at the very end, I want to finish with a story that really I think is so critical.
I'm going to keep you here till midnight. This is too damn good.
What we could do is, I appreciate it. Thank you for listening. So let's take the scenario with number 19. So we took the bite of the apple, the tongue pulls the food back, and we're going to chew. So where is the most power? The most power is going to be on the most posterior occlusal table. If they have their wisdom teeth, it'll be there. If they don't, it'll be on 18 and 31 and that area. Why? Because you're closest to the hinge. Where's the hinge? The anatomy of the hinge, if you put your finger just in front of your ear opening, that's where the hinge is for the mandible. Okay, so the closer you are to the hinge, the higher the leverage. So I told you tooth number 19 is super erupted. If tooth number 19 is super erupted and we put an implant in number 14, and then we restore it with a crown and we don't ever touch number 19, we just created what we call a high interference. A high interference means it's interfering with the normal natural plane of occlusion, which is the curve of Spee to retromolar pad. We have a deviation from that. Le Chatelier says we stress the system's going to react to relieve the stress. The patient is going to chew on that side better. Why? They have higher leverage. It's closer to the hinge. And intuitively, the patient isn't even going to understand this in a conscious sense, but they're going to say, I chew better on that side. And that's because the leverages are higher. Okay, so the surgeon does a beautiful job and he places the implant and the bone heals and everything is going great, and you place the restoration, and 3 years down the road, there's vertical defects around the implant. And the surgeon says, must be the patient's biology. The patient isn't cleaning. The patient isn't compliant. It's always something else. Well, it's high leverage. What's happening is you're pounding that implant and that tooth, and you'll start to see breakdown of the structures supporting those chewing devices. It's high leverage. Okay, let's take it a step further, because now we go to another chapter. If you're chewing more on the side that's high, what results is the musculature of the face is going to develop differently. So if in this example in number 19, the left masseter and the left temporalis is going to be very, very defined, like going to the gym and working out and being very, very ripped. The contralateral side in this example is the right side. It's going to be more atrophic. So as you develop some skills in this, you can actually understand some occlusal problems extraorally. When I first say hello to the patient and I'm watching them in the chair speak with me, I'm watching masseters, I'm watching contours, I'm looking are things convex or concave. It's the game within the game. As you develop your skills and the patient opens their mouth, says they have a sore tooth, and you smell the infection. See, now you're using additional accessory sensory perception to get as many clues as you can to figure things out. Okay, so when I was a kid, I was playing baseball down at the Jersey Shore, and I was right out of residency, and the pitcher got into a little fender bender, had to wait for the police to file a report. I was new to this team. I just left Boston and started as an associate in a practice down there. So the coach says, you're going to go in and pitch. And I said, okay, great. So the first thing you look at is the flag in the outfield. Which way is the wind blowing? Because it's by the beach. So oftentimes the wind is a heavy factor, right? So the wind is blowing in my face. It's blowing out to the outfield. So I said to the catcher, we're going to throw curveballs, screwballs, anything but a fastball, because when the wind is blowing at me, the ball has to go through the air to get to the catcher. If I throw a straight fastball, it's going to slow the ball down. We call it becomes a grapefruit. Okay, they're going to hit home runs. So this was like a college warm-up, for like the minor leagues and things like this. It was just a tryout. I figured I'd try out as a joke. I made the team. So we're having fun. I'm pitching a perfect game through 3 innings. Perfect game. And the wind shifts, and now it's blowing at my back to the catcher. So the catcher's putting down a curveball. Well, a curveball with the wind behind me, the wind is going to push the ball. It's not going to move because friction is what causes it to curve, right? The game within the game. That's the relevance of the story. So we go fastballs because now the fastballs are going to pop. And what's great is they haven't seen the fastball for the first couple of innings. So at the end of the game, he says to me, look, you got to walk a guy, get a guy on because I'm being scouted. So I see 2 scouts. They're like older than dirt, chewing on both ends of the cigar, the typical classic stereotype of a scout. And I said, all right, so we walked a guy, and I was able to pick off the sign. I knew that they were going to run because they didn't have a runner. So typically they touch their belt. Belt means either bunt or sacrifice or whatever they're going to do. So the guy run, I throw a perfect pitch out. The catcher throws a bullet down to second base. So at the end of the game, they invite me to come to instructional league ball, right? But it's all the game within the game. So when you pitch, like you would think you would stand facing the catcher and put the ball by your ear and throw it to the catcher. And if I did that, it's hard to see on a recording, but you would say I throw, quote unquote, and no offense, I throw like a girl, okay? It's actually not like a girl, it's called short arming. And the only player on the team that can do that is the catcher because they put the ball at the ear and they throw. They have an incredibly strong arm. But anybody else, what they do is they put their front shoulder towards the target. The ball actually comes up and back and faces behind, away from the target that the player is throwing to, and then they whip the ball forward and throw it to the target. So if you were to break down the steps of throwing, and if you see these fathers who coach Little League, they have no clue of how to do it. Most errors in the Major League are throwing errors. So when I coached my kids in Little League, everybody became a pitcher because if they were accurate there, I could take mediocre team and make them into a championship team. That's the key. It's the game within the game. It's all the mechanics. Redoing old cars, it's all in the mechanics. I'm into Krav Maga heavily. We talked about that a while back. What I find fascinating about Krav Maga, it's all mechanics. How to take a gun, how to get out of a knife hold, and that kind of thing. It's all understanding the ligaments, the tendons, the way the joint works, everything else. So if you listen to, I often wonder when I sit there and I've taken all the advanced TMD, TMJ courses, and the correct terminology many people argue is TMG, but what TMD because it's dysfunction. But what does it really matter as long as you're conveying what it is? But does an orthopedic surgeon sit there for a 3-hour conference on the neuromuscular reaction of reconstructing an elbow or a knee? Like, do they sit there and talk about how the big knuckle of the big toe is related to this parasympathetic nervous system? Does it make any sense whatsoever? Okay, look, it's great information. It's very cerebral. I've taken all those courses. Every bit of information. But you started off by saying there's all these different camps and philosophies, and a philosophy is not a principle. And I'm showing you physics in the mouth, geometry in the mouth of proven principles. They're indisputable. They're documented. They're utilized in other industries. It works all the time, every time. Now the big thing is all on 4 cases. And we're doing the cases where we place the implant, say, Monday morning. Tuesday at 2 o'clock, we deliver the final case. Final case is done. It's a titanium bar with acrylic, and then we can convert them to zirconia if so needed. We have some cases in the mouth, 7-8 years, still in the acrylic, looks like the day it was put in. And when I place it, and I could tell you anything on here, but the proof is in it. If you follow what I'm telling you, my occlusal adjustments when I put a full arch in is maybe 6 minutes. We have it on videotape because my surgeon is in the office with me, and he actually absolutely marvels at how he asked me, he says, I make too much money. He says, I don't work hard enough, because he's doing all the heavy lifting. I said, no, it's all the setup. Because from the wax setup of what we're doing to the correct plane of occlusion translates to a surgical guide, which translates into the correct orientation, which translates into the correct leverages, which translates into long-term success, which then translates into creating a referral machine. So I'm in Boca Raton, Florida. There's probably 180,000 dentists in my town. Like, there's so many dentists in my town, I don't even know if another dentist could come in, because every dentist has an exclusive in the shopping center that they're in. So when I went there many years ago, someone said, why are you going to Boca? It's like the lion's den. And well, I grew up part of my life there, and I had great times, and I thought, well, I'm going to give it a shot. Why can't I give it a shot? So one case at a time, I started my practice from scratch, and yeah, there was debt, and everyone says control your expenses, of course. But you said, how do these people know which camp to go down? And it's a colossal question, and the answer is a heavy answer, because if you calculate the cost of going down one road or another, it gets staggering. Forget the actual tuition dollars. You have time out of the office, and the most costly expense is time away from your family. That, for me, was the highest cost. I have 4 kids. I want to be with the kids. I want to maximize. But why did I take all these courses as early as I could? Was so that, practice doesn't make perfect. Because if you learn to do something incorrectly and you practice it, you will become very proficient doing it incorrectly. But if you learn perfectly how to do it, or as close to accurate as you can, and you practice that, you'll enjoy success your entire career. So I once said to Dawson, I did attend Dawson seminars. There was about 600 students in seminar 1. And my hygienist actually grew up with his daughter, so I had a little inside track to him, which was unique. And I've had lunch with him several times, and it's a very, very fascinating experience, and I respect him. I don't agree with everything he says. I agree with parts of what he says, and but I do respect the man tremendously. I said to him, Dr. Dawson, out of 600 students here, how many do you think will implement what you're talking about? They took time away from their practice, time away from their family. They traveled by plane, car, whatever. They stayed in a hotel. They're paying huge, it was like $3,500 for a 3-day course, big money, and they weren't in the office, and the overhead still goes. So how many? And he looked, scratched his head, and he said, maybe 1%. 1%, Howard. That's incredible, incredible. I got to seminar 3. There were only about 30 students, and one of them was buying an articulator for the very first time. How can you implement anything if you're not, so people say, do I trim my own dies? Every time. It takes me 3 minutes to trim the die because the impression is usually good. If it's longer than 3 minutes, I throw the die out and I start over. It allows me to continually assess my own skill level. It allows me to see, did I have a bad day before it becomes a bad day to the patient. It allows me to quality control, to check how am I doing, is it going to work? The way we charge the fee plus the lab bill. So I'm not a usual and customary kind of person. We're fee for service. We do care nursing. We don't have a front desk. We have 2 care nurses. Instead of having one lady at the front desk and one assistant, and I dislike that word as I know you do. What happens is I have 2, and they're totally cross-trained. Now, back in the day when you and I started, it was 1 paper appointment book. Today I put credit card terminals in every treatment room. I put telephones in every treatment room. I put computers, obviously, in every treatment room. I have digital radiography in every treatment room. Just like nothing that's so remarkable, but that's what we did. And in every room, there's a front desk. So now we have a private lounge or operatory for that patient. If Tiffany, her patient is scheduled at 10 o'clock, she knows that patient's coming. She knows who they are. She knows everything about their family. Every time Mrs. Jones, we'll use the name for an example. Every time Mrs. Jones comes, Tiffany is her care nurse. Tiffany escorts her to the treatment room, just like greeting someone at the front door of your house. They don't sit in the waiting room, they come right into the treatment room. Once they get to the treatment room, she knows the treatment that's going to be done. Let's say we prep and temp for a crown. She certainly knows what the next visit's going to be, is to insert the crown. She knows which lab it's going to go to, and then she knows how much time is necessary between appointments. So Tiffany's going to accept the payment in the treatment room. She's going to schedule the next appointment. The patient never discusses anything where someone in the waiting room can overhear the conversation, ever. Totally private, and then the patient simply leaves. And then Vanessa is my other lady, and she'll be escorting the next patient back. So people say, who answers the phone? Who's ever free? We do have a hygienist, Mary, but Mary's usually always busy with her side of things. So it's lean and mean. We're happiness centered. If you're over my shoulder and I said to Tiffany, could you please, I need a cleoid discoid. So I'll say, Tiffany, can I please have a cleoid discoid? Now this sounds really corny, but this is what your grandma did, bouncing you on her knee, was teach you to say please and thank you, right? Now guess who's listening to my please and thank you? The patient. The patient is overhearing the whole thing. So most dentists, and I've worked in a lot of different offices. When I was in residency, I was moonlighting, and as an associate, and where do you work? You work at these, low-end mills, capitation clinics. One place had a barber chair and a shop vac and no assistant for me. And it was the best experience ever, because it taught me I never want to do this again. And I got good at it. You make do with what you have. So these are the things. So if most dentists will throw instruments, I've never seen someone do it, but you hear these stories. They're mean and nasty. That person is breathing their own breath, pouring their heart into the treatment, just like me. And if I put them on a pedestal higher than me, it's a reflection of me. I hired that person. I picked that person. I created that person's skill set to be next to me. The patients will actually give a hug to the care nurse. Now, who do you think asks for referrals? The care nurse is in the most advantageous position to ask for referrals. And after all, it's nice to have a referral machine. So I was once kayaking in the still waters, in the backwaters in Naples, Florida, on the West Coast. And I see this, I'm not into fishing. No one ever taught me. So I grew up in New Jersey up there. So this fella's throwing a net off the bow of the boat, and the tide was running. So I was doing it for exercise. So I was able to row in place and keep my boat where it was. So I was getting a good workout. And he hauls in the net, and he starts going through the net, and he puts one back in the water and one in the bucket, one in the water and one in the bucket. So I row up on him and I said, can I request permission to speak with you for a second? Because I don't want to interrupt. It's his vacation time, He says, yeah, what do you want? I'm really busy. I got to get out to fish. I said, well, you've been here for 45 minutes. Yeah, I know. I got to get out to fish. I said, well, what are you doing? Because I'm not into fishing. Could you just teach me? Well, I'm looking for certain types of fish, and some meet my criteria, and I put them in the bucket in the boat, and the others don't, I throw them back. So you put an ad on the radio, and you get 200 new patients. You got a huge net. Now I personally don't have time to go through that net and throw them back. So if you can get a referral machine, then everybody who comes in is preheated. They know what we're about, what we charge, what we do, how we do it. And this goes to another podcast with critical non-essentials, super critical non-essentials, things that you do in your world. I worked at the Playboy Hotel and Casino in Atlantic City between college and dental school. I was fascinated by the environment, by the culture that was intentionally established in that arena. So if you don't create a culture in your office, it's going to be created for you. I've heard people on podcasts say, well, ask your patients what they want. You can't ask what they want. You have to set it up the way you want, and then deliver it the way you want. So we have a big sign. It says, "Ladies and gentlemen, serving ladies and gentlemen." You know where you get that? The Ritz-Carlton. So we copied the Ritz-Carlton. We're no better than they are. They're no better than us. And we treat some heavy hitters. I mean, you see them on TV and that kind of thing, and they come in with a boatload of money. But the one criteria for sure is they're all nice. Because 15 years ago, I dismissed 60% of the practice. 60. The mode was, in those days, take anyone who comes in because I got to pay the bills, right? And that's, the way a company develops. You go up and then you plateau and then you come up again and plateau. So I had it. I couldn't take it. I wanted to buy a Jiffy Lube or something like that. I just couldn't take being in practice. And if you think about the worst times that you're at the chair, it's usually at the hands of an unreasonable patient. It has nothing to do with the dentistry. Things are going to go wrong. Business is tough, right? Business is difficult. That's definition. But what you want is, you need someone who's reasonable on the other end of your handpiece, someone who understands and who's a friend, right? Who you have your care nurse as an advocate for that patient, always looking out for that patient. You're always treating them with the right ethics, and like Pankey, in his book, know thyself, know thy patient, and know thy work. So when I speak to a dentist after they got sued, I said, "How well did you get to know the patient?" "Not at all." I said, "Why did you do that procedure?" "I needed the money. It was a little over my head." I said, "Now look at the time you spend in deposition, sleepless nights, a bad belly." Thank God I've never gone down that road, because I have reasonable patients. They understand if something goes wrong. Of course, every single dentist listening is going to make it right. No two mouths are the same, and there's different quirky things. But if you don't understand the basis of occlusion, you don't understand the basis of function, and if I speak to people at some of these advanced meetings, and they'll get real belligerent, and I just listen, and then I'll say, "Can I talk to you for a second on the side?" I say, do you got all these accolades? Do you know the steps to function? And this is a person maybe in their early 70s practicing, and they'll say, "What do you ask me such a question for?" "I've been practicing for 45 years. So that leads to the next question. Do you have 1 year of experience 45 times, or do you have 45 years of experience? And I said, you still didn't answer. How do you masticate? What are the steps to function? How can you fix something you don't know? How it works? And they stand there, and you should see. And so Dawson said to me, when Pankey Man Schuyler in the 40s, after a seminar, they would go into a hotel room and discuss occlusion till long into the night. Why? Why do you have to discuss occlusion for so long? I just told you about leverage. Leverage is physics. So let's take the reverse. Let's say that number 19 is missing, and number 14 is super erupted. Now you build a bridge. We've all seen it. It comes nice and level at number 20. It dips down on 19, comes back up on 18, but it's perfectly equilibrated. It meets all the equilibration protocols that Pankey, Man, Schuyler, Dawson, Coy, Spears want. Equal contact all over. The tech scan will do it, because that's another discussion. I've done studies with the tech scan. The tech scan will show you that the points are all even. They're all even. All right, so they're all even. But what happens? Le Chatelier says that there's a stress to the system. So now you're further from the hinge. So the contralateral side, the right side, is going to be the high side. Even though the right side is correct, it's high relative to the left side, because now the left side is low. So what happens is, intuitively, they're going to favor chewing on the right side. So all of a sudden, you start to see secondary occlusal trauma. That means that there's overload to the periodontium and all that. The widening of the PDLs. There's going to be some mobilities of 1 or 1 plus or whatever it is. You start to see some furcation involvements, and you scratch your head and you say, geez, as Ben Franklin says, Mrs. Smith, you're getting long in the tooth. You're getting older. Well, that's a cop-out. It means you don't know. You don't understand that there's a compromise on the left side because there's such low leverage. And the patient will actually say to you, and if you think back and you're honest with your own self, they'll say, you know, I don't chew that well on that bridge that you made me. Because it's happened to me, because before I knew this information, we did this. Well, they're just paying me, in dental school they would say, they're just paying you for the lower bridge. Don't touch any other teeth. Okay, so now we say, okay, we want to correct that super erupted number 14. All right, well, how far is it super erupted? So we went through the impression, and then we put it on the articulator as orientation. And after orientation, we went through evaluation. So evaluation is you run your fingers over the model, you could feel high bumps and low points, and you could actually then go into calculation. After evaluation is calculation, and you say, okay, let's make a measurement. Let's make a measurement, right? So how do we measure? We take a caliper and you draw a line of the occlusal cusp tips on the buccal is, say, 12 and 13 and 15, and you notice that 14 is, say, let's say it's a half a millimeter or a millimeter, so it's significant. It's a millimeter super erupted. Well, can you do coronal reshaping within a millimeter? Generally, yes. You might go through the enamel, so you could put a little composite or just leave it, and you explain to the patient this is what you're going to do. All right. Let's say it's 5 millimeters super erupted. Now you're going to cut the tooth in 5 millimeters. What are the odds that you're going to hit the nerve? Very, very high. Now, if the patient's in their late 90s, it might be less, but still, nevertheless, you're more aware that you're going to perhaps hit the pulp. Okay, so what happens then is you're developing what's called a treatment plan, right? Now you're a physician of the stomatognathtic system. That's what Dawson would always say. So you want to be a physician of the system. So now, or a biomechanic of the system. So now you say, okay, we're definitely going to have to put a crown on number 14. We don't know if we're going to need an endo post-core. If the attachment apparatus is super erupted along with it, you might need crown lengthening. When you add all that up, you might say, well, we don't really want to go through the expense of all that. Why don't we remove the tooth, strategic extraction, and place an implant in a more harmonious manner? And then when you place the implant, my surgeon has measurements to know where the top of the implant must be in order so I have prosthetic ability to place the tooth within the correct plane of occlusion. You see how you work backwards, that the plane of occlusion dictates everything that's below it or that's supporting it. So now you can correct the number 14, then you make your bridge perfectly correct opposing it. So I guess maybe I could be a dental consultant and double everyone's practice, because now you're not just looking at the 3-unit bridge, you just got endo post-core crown, or you got implant and implant crown and a 3-unit bridge. And that's secondary to everything else. But that's how you develop a treatment plan. So after calculation becomes fabrication. And then after fabrication, you do insertion. And there's one other in there is modification.
Where was modification?
So let me see. You have evaluation, calculation, modification. Modification would be your treatment planning stage. So we discussed whether it's a millimeter super erupted or 5 millimeters super erupted. Then you can go into fabrication, because now you know what you're going to fabricate based on what you're going to modify. All right. And so this IONS is a good 3-hour presentation just in that, because there's.
Are you going to put that on Dental Town?
Yeah, I'm gonna do it all for you.
Oh my God, that'd be awesome.
I'll do these courses in modules because it's just overwhelming I mean, we're covering a lot of stuff, culture, from how the patient comes into practice, the mindset of the patient, the understanding of how I'm going to approach this. They know that this is what's coming. And they'll say, I've never had anyone discuss this with me. And I use the scissor analogy. It's the easiest analogy because they understand it. Learning is taking old, new information and joining it with old. So now you have a working model. So we talked about leverage, we talked about function, we talked about the steps to function, we talked about the ions. What questions do you have?
Well, unfortunately, a lot of the podcasting is an under 30 behavior.
Right.
So when I go to, there's 51 forums on Dentaltown, and number 51, because it starts with T, TMJ, TMD, a lot of their questions are more intro, like, when do I need an articulator? Because my instructor told me just use a quadrant arch. When do you need to upgrade from a quadrant arch? And another thing is with the lectures. When you go to dental conventions, all the lecturers are in full mouth rehab. Mm-hmm. But when you go talk to all 7,500 labs, they say 94% of crowns come in one at a time. So talk about where do you cross the line between an intro and a quadrant impression tray versus an articulator?
Okay, great question. Absolutely. A quadrant tray is very, very good because it's convenient. You get everything in 4 or 5 minutes, because you should know how long it takes your impression material to set up and have a timer on so you know when to take it out and all those things like what we do. So in 5 minutes, you're done. You have the bite, the impression of the tooth in question, and the opposing. The problem is when they go to mount it, they don't have references to put it on hinge axis. So now you know that when the crown comes back, emotionally you're going to plan to adjust that crown a lot. You have to, because if the crown is dead on, it's just by virtue of luck that the orientation of the triple tray was placed on the hinge of that triple tray in the exact hinge axis. It's 1 in a million. Well, every dentist out there understands this. And most of my practice is single crowns. I mean, we're doing a great deal. 80% is probably implant related. I don't do dentures. I don't do any removables in my practice, ever. That's my rule. Most lawsuits are for removable dentures, by the way. It's usually a 400 denture at some, quickie denture clinic, and the patient's not happy and they sue. But patients are never happy with a denture. It's always below their expectations. I've never met a happy denture patient. So yeah, I agree that most of the crowns are going to be onesies or twosies. A 3-unit bridge is few and far between because now we have implant restoration, so you don't have to do joining a teeth unless there's a medical condition or the sinus or something like that, anatomically speaking. But I agree with you. So when do you need an articulator? Well, if you're gonna do this type of work, obviously there's a great deal of training to understand this whole thing, to implement this thing. The laboratories are going to trim your retromolar pads off. They are going to trim them off because when they send them back. Let me just speak to this. Let's say you're doing a crown on number 18. There's no number 17. So you would say, well, what do you do with retromolar pad? Yeah, we capture retromolar pad. I mark it on the model. I'll mount it, or usually my laboratories now are very well versed in this, so that they'll mount it with retromolar pad. So they'll Pindex the retromolar pad. So retromolar pad is preserved. We get away from retromolar pad with fixed because it lasts long enough until it fails that the patient is understanding, okay, nothing lasts forever. That's a cop-out. It fails because the leverage and everything. It fails because it's not done to the correct physics and biomechanics. So the true term for all this is biomechanical gnathology. If you look up in the glossary of terms like the Journal of Prosthetic Dentistry and the prosthodontic circles that define centric relation, centric occlusion, and all this other stuff, and I'll tell you about that in a second. They define gnathology as it's the art and science of the teeth, the intraoral structures, the extraoral structures, the musculature, the temporomandibular joint. So there is a whole nother segment on, okay, let's say we have that high interference on number 19 is super erupted and 14's been missing, and then they're favoring that side. What happens to the TM joint? There's definitely an effect in the TM joint because you're stressing the whole system, and that's another topic. So So with regard to the onesies and when do you need an articulator, you can get any articulator system. I have built for studies. We had I think eight or nine implants on a mandibular arch. I built the whole case on a simple hinge articulator, and I think I even videotaped it when I inserted it. That there was maybe 6-7 minutes of occlusal adjustment, just tweaking some things. Okay, so because if the mandible goes lateral for function, then you need what's called freedom in lateral. For the younger dentists, maybe they don't know Pankey and Schuyler, but they were the ones who came up with long centric. Remember that term, long centric? And it's like, okay, you build everything on the articulator. What they do is they take the thumb and push it on the chin and push the mandible posteriorly to get it into the highest, midmost, centermost, uppermost, whatevermost position in the fossa. And what you're doing is you're jamming the mandible all the way. And arguably it's valid for the sense that it's a home position. It's like that. But what if the patient's in spasm and you can't get one side in because the muscles are fixed? Okay, that's another discussion. But let's say you get it in that position and you mount it on the articulator in that position. What happens is you're building the case in a position such that the medial poles of the condyle are in contact with the skull base. And if they're in contact bilaterally with the skull base, and if you looked at a skull, a replica of the skull or whatever, and you saw this, it would immediately, you would understand it. You cannot move laterally with the right medial pole in contact. You can't move left, and the left medial pole is in contact, so you can't move right. So Pankey and Schuyler understood this. I don't know that they identified it, but they understood that they couldn't move. And they would create a long centric, because then the patient could actually come down the eminence a little bit, just enough to get the medial poles free from the skull base, and then the patient could actually move lateral and function. So they were building in slop because of the home position. And that's why there's great controversy with centric relation, because can you really build to it and function in it? And the answer is no. Anatomically, it's impossible. But no one has ever done any studies, because I did a literature review for several years on what are the steps to function. And I think Ash wrote in the early 1900s, and I have all these citations, but he said it's in his book that it was incising, crushing, milling, and deglutition. Those are the 3 steps. So you have incise, crushing, and milling, that's a direct quote, and deglutition, a direct quote. Well, deglutition is not mastication. It's a result of the completion of mastication is swallowing. So that's not a step, so that's wrong. Incising is correct. Milling and crushing is correct, but you need something to get it from the incisors to the area that's going to mill and crush. That's the tongue, the role of the tongue. And then the tongue maintains it in position. So having this working knowledge, now, I've approached some people with the neuromuscular, I've approached some people with other camps, and I said, I want to do a study I want to see your results, I want to impression it with retromolar pads, I'm going to take Haas Smile Line, I want to put it on the articulator, and we'll do an analysis. That's all I have to do. I'm not going to mess with your work, I'm not going to bother with your patient. I'll teach you how to do it if you could just give me the information. And no one will do it. They won't do it. I said to several neuromuscular guys, and they're pretty prominent, I don't want to name names, but I said, look, maybe you go to the right and I go to the left, and we both end up at the same finish line. And that's cool, but let's check it out, right? Because there is some criticism of the myomonitor that when the air conditioning system comes on, it blows, the myomonitor starts getting affected by the blow of the air conditioning. And so it came out of disfavor when Jankelson did it. And I don't know that much about it. I don't use it. I mean, there's centers that are built that are very prominent. I've heard the people speak. They're very, very cerebral. It's been around long enough. It most likely works. But you always said, if you quote me, date me. Gordon Christensen on Dental Town, one of my slides that I always show because I have such regard and respect for Dr. Christensen, he said in Dental Town, he said, dentistry as it relates to occlusion is in, quote unquote, is in chaos. And that was 2009, so I'm dating it. In 2009 to now, there have been no landmark articles, no landmark discoveries, no new seminars that have come out that are exploding on the scene that's having the dental schools change all their protocols. So the assumption is from 2009 to now, nothing new has introduced. If Dr. Christensen, who I hold in very, very high regard, if he is in chaos, right? We'll use the transitive property. He says dentistry is in chaos with respect to occlusion. Dr. Christensen is a dentist. He's also a prosthodontist. If he's in dentistry and dentistry is in chaos, then Dr. Christensen is in chaos. Is that a fair statement? Without any subjectivity, it's just fact. Well, then I'm in chaos, you're in chaos, everybody's in chaos. We're just controlling the chaos. It's like, I guess, when you have little kids, right? You control the chaos, right, Howard? So, well, why do we want to control it? You know, I've burned out so many times. I said to Dawson once at a lunch, he was kind enough to have me for lunch. He says, so how many times you burned out? I said, I don't know, 4 times. And he said, good. And I said, good? What's good about that? And he leaned in and he said, the only person who burns out is the one who's been on fire. And I thought, okay, that's cool. So my passion is that high, but it's not healthy, and it affects me. It affects my family, and that brings me to the customer comes third, right? There's that famous book, The Customer Comes Second. Well, in our office, it comes third, and it's really first, but this is why it's third. I go home, I work out, I sleep well, I eat right, take care of myself, play with my kids, have a fulfilling life at home. I have a fighting chance to come to the office and be happy. So now I'm happy, and I am. And then each one of my team members is encouraged to do the same thing. If they don't, they're no longer welcome in the office because I can't be around unhappy people. So they come in happy. So now each member of the team is happy. Now the team as a whole can impart happiness and a good culture and good karma to the environment that our customer is coming. So now what we hear all day is, especially from new patients, is this place it's almost like it's fun. It's not. When we play baseball is very dangerous. When you coach little kids, there's bats, there's hard balls, kids can get hit in the head. You know, that little kid, Bat Boy, got killed by an accident, getting hit in the head with a helmet. It's very, very serious. So we would say baseball's fun, but it's not funny. It's not funny. It's not a joke. It's not something to be taken like golf. If I took my kids to play golf, there's a protocol. They sit on the bucket. They don't get in the line of the swing of the other kid who's hitting the ball, right? It's like, or you go to a gun range, you know, if you do something like that. It's fun, but it's not funny. Dentistry in our office is fun, but it's not funny. It's not sloppy. It's not ridiculous, but it's fun. So people want to do business with people they like. People want to do business where they're comfortable. People want to do business where there's trust. People want to do business where there's happiness. Happiness, I'm reading Psycho-Cybernetics again. I read it many years ago. I just read some on the plane coming in. There's a whole chapter devoted to happiness because he's a plastic surgeon changing scars on people. Well, what happens when you change a scar in someone's face? What happens to the psyche? What happens to the happiness? This is what he talks about. It's a brilliant book. He passed in 1975. So I think the book was written in 1960, if I remember right. So brilliant, right? Brilliant stuff. So to the 30 and younger clinician, I want to say most likely you've run into colleagues who are less than nice and less than collegial, and I want to apologize for that because dentistry is a very competitive, and it's fostered in dental school. It's a very competitive fish tank, and it shouldn't be. There's enough people to go around if you do it right. And so welcome to the profession as a colleague and a friend. And you know that I got your back because I don't sue. I don't go against other dentists ever, ever, ever. I only take the dentist side. And when you do it right and you do it well and you do it for the right patient who's reasonable, you shouldn't even need malpractice insurance. Do I have it? Of course. Yes, you have it. In the state of Florida, I think you have to put $250,000 cash in an account. I have friends who do that, but anyway, so we can get into some of the very heady, as I heard someone say. But if it's all basic physics, and we've taken all this, and I haven't told you anything new. I just took the puzzle and put the pieces in a different order, and it should make better sense, right? Now, when you come and you're going to equilibrate an arch, and I talk to some of these quote-unquote gurus, okay, we're going to equilibrate the arch. We got to get it equilibrated, perfectly equilibrated. Okay, how? Well, we're going to take some off here and off there. Why? Ask them why. They don't know. Like, if you take some off the lower tooth, is it the correct tooth to take off? Did you do your evaluation? Do you have proper orientation? Did you do the impressions to capture the landmarks? Do you know what the landmarks are, where the landmarks are, how to use the landmarks, how to measure and do the modification, the proper modification, and then what's the long-term result? So that's where we are. I don't know if we're getting near time or what.
No, we can do it all day. But back to that single unit, that first molar crown. So would you take a full arch impression?
Yeah, a lot of times I'll take a full arch impression. It's just my protocol. I'm up and
so you don't do quadrant trays then?
Sometimes if it's emergency and I just want to get the case done.
But for your standard operating procedure for a molar, a first molar,
yeah,
you would take full arch.
I'll do a full arch. I'll do an opposing upper, because now I'm evaluating everything else, and most likely there's more dentistry there.
So you're even though you're a prosthodontist, you're like the general dentist where the majority of your crowns are one at a time?
Yeah, I'm primary care. I'm limited to restorative. I'm not.
I want to ask you this. And a lot of these kids, one of their first questions are, they're coming out of school $350,000 student loans, and they're being told to be a quality dentist they need to spend $150,000 and get a CAD cam, and that's what would you say to her when she's she's 350. If she buys a CEREC machine, she's now $500,000 in debt.
That's huge. That's called stress. I'm the son of an accountant. That'll cause you stress.
Can you be a high quality dentist by using impressions and sending to a lab, or should you use all digital dentistry like they're being told?
Well, I'm starting to embrace digital dentistry. I will be candid with you. I understand that the quote, good is the enemy of great. From what I've seen and what I've heard and a lot of the inside track is the digital dentistry is coming. It's not perfect yet. It takes a little longer to do. It's more expensive to do, and it's no easier to do. So it defies all the basic criteria that I want when I want to make it.
And say those criteria again. Say them again.
Okay, so it's more expensive, more time consuming, and more difficult.
Yeah, and what does everybody live by? It's got to be faster. It's got to be easier. It's got to be better, and it's got to be cheaper. And the old guys, all the millionaires I know, they take a polyvinyl impression or polyether impergum, and they send it to a lab man who's made 1,000 crowns a year for decades, and they say, you know what? It was a $15 impression, and I sent it to a lab man, and he gave me back a crown in 2 weeks. Now I'm going to buy a $150,000 machine. My dental assistant hasn't made one crown in her life. Now you know what I mean? And now so they got $150,000, and they say it's faster. Well, it's same day. Well, this was an hour appointment, and then they come back in 2 weeks for half an hour. Now I see him sitting in the chair for 2 or 3 or 4 hours. So same day does not equate faster. Was it easier? Ask you've never done this before. Your lab man's done it 10,000 times. Is it better? Yeah. Is it cheaper?
It's not cheaper because
I know.
You have to pay
and so many people, they just swallow the suit that they just got to go. And some people say, okay, I'm not going to get a CAD cam. I'm just going to get an oral scanner. It's like, okay, so you had a $13 polyether impergum 3M SP impression, And now you got a $30,000 scanner, and then just like the software update each year is $1,000, and the HIPAA compliant, and everything's just totally complicated because you didn't want to take a lousy $13 impression and put it in a box and give it to somebody.
I agree. I mean, I'm old school. I like PFM. I've done a number of zirconia cases. I've had untoward tissue reaction. I think people are going to start speaking to that. Years ago, there was Dicor, if you remember Dicor.
Oh, do I remember Dicor?
Crashed and burned.
Oh, my gosh. Can I tell you my Dicor story? So I'm sold. Got out 87. They said, if she's really good looking and she's hot. And you want Dicor crowns. And what'd they tell you cement them with? Duralon.
Yeah, right.
So I was doing all these Duralon crowns with, Dicor crowns, Duralon. Guess how many of them fractured and I had to replace for free?
All of them.
Every last one of them. And that's one lesson two old guys can tell you is that when something comes out new, it's called bleeding edge. Let all your idiot friends do it and then come back 5 years later and tell me how it worked for you. But you don't get, guys, I got a granddaughter. You don't get grandpas to jump at anything new. How many times have you been burned in dentistry?
Yeah, I'm never going to go down that road. In fact,
remember Targus Vectors?
Oh yeah,
one of the biggest companies in the world.
Right.
This is the greatest thing. Well, I don't know what Targus means. I don't know what Vectors means, but I know they hated each other because they all came apart. Remember Art Glass?
Oh, it's horrible stuff.
I mean, it's just like when someone shows me something new, I'm like, can't you find someone under 30 to try that for me? I'm 50.
I'll tell you, art glass. During my residency in Boston, there was a fella in the endodontic program. He's from this area, I think from the Phoenix area, as a matter of fact. And I got to know him after a couple years there, and he finally broke down and told me, he said he had to sell his practice because there was a class action suit against him because there was so many crowns that had failed that if he redid them, he would have been out of business. So he just closed, left, went to endo to become a specialist. I'm not sure where he ended up, but certainly not back in his hometown. And he had to change his whole paradigm because he was on, you say the bleeding edge, the cutting edge, you get cut and then you're bleeding for sure. So I'm very traditional. I do a bulk of my work is PFM crowns. Like I said, the zirconia, I'm starting to see zirconia. The emergence profile is absolutely horrible. It's very thick, very bulky. I've used several different really top-notch laboratories, and it's all consistent. So I'm starting to do the lab work when it returns because I see the bulges. It's not the proper contours out of the sulcus, and I take it in the lab in my office where I'm the technician now, and I'm starting to grind straight emergence profiles. It's ridiculous. It's absolutely ridiculous. So I quit that. When I cement my PFM crowns, a little off topic, but it'll help the younger guys and gals. We did studies in residency. When you cement it, obviously in the 360-degree margin area, the cement oozes out. But what about the stuff that gets stuck in the occlusal? So here's the typical scenario, and everyone's gone through it. They cement the crown, they equilibrate the crown, they cement it, they take the gloves off, they're walking out of the room, the patient sits up and says, "Hey doc, the crown is way high now." Okay, your margins are open, your cement balled up in the occlusal, you're gonna now grind that back, you're gonna probably hit metal or whatever. It's a disaster. So what I do is I prepare the central fossa and the grooves very defined and significantly, and then I tell my laboratory, give me a little extra thickness of metal there. Inside the crown, before I cement it, I'll grind out a little of the metal to create almost like a reservoir, even though they use quote-unquote dye spacer. But we've done studies on that. If the dye spacer's around more than a month, it's gummy, thick, the coating. You take this to the infinite level, and we've done all this stuff. So dye spacing is nice, it helps, but it's not the end all. So
do you need to run, or can I ask you some more questions?
I'm all yours.
Okay, here's another question they walk out of school and say. They say, Howard, it seems like the guys that teach occlusion have never done one ortho case, and the guys that do ortho have never done an occlusion case, because they say things like they learn the occlusion thing, then they see there's 9 specialties recognized by the American Dental Association. The biggest one is orthodontist, 10,800. In fact, if you cut orthodontists in half, each half would be bigger than the second biggest one, oral surgeons. And they say, well, orthodontists all day long blow out the curve of speed, the curve of Wilson, canine guidance to group function. They say, if you believe occlusion, then explain orthodontics, because America puts a gazillion children a year. I think 3% of Americans a year go through ortho.
Yeah, great thing. As you mentioned in my bio, I went to the Goldman School. It's
Goldman Sachs?
No.
Teaching you
some
was
days,
that your MBA
some
program?
Days I think I should have. But no, the Goldman School of Graduate Dentistry up at Boston. It's interesting that in my area, there's a huge amount of graduates from Boston University in their various specialties. And somehow, some way, we seem to migrate to each other. I spent a lot of time in the orthodontic department when I was in my residency. I had a couple friends there, so it brought me down there. The head of that program at the time was Anthony Gianelli, absolute genius. He had a PhD. He graduated from Harvard for college. He had an MD, and he had a dental degree, and he was an orthodontist. He had a photographic memory. I have sort of a photographic memory. Sometimes it gets a little foggy, the lens. His lens never got foggy. I could start quoting something, and he would continue the quote for several more sentences. That's how it was. So I found it very interesting, because I took to occlusion right away, because I understood that was dependent. Occlusion dictated my success. I understood that early on. I understood the deficiencies in knowing. So when I converse with an orthodontist, it's usually a BU grad, and I'm not touting BU, but the people that I'm interacting with they're very, very cerebral to understand retromolar pad, curve of spee. And maybe working with me for so long, they know what I want. Now, my practice is generally the sixth, seventh, and eighth, ninth decade of life. So like, we once had a lady who was in her 90s call and say, do you treat kids? And we said, no, we really don't. We'll treat a 15-year-old girl who's congenitally missing some laterals with some implants, and then send it back to the pediatric dentist. So we don't. I'm more of a prosthodontic type of practice, restorative dentistry, and our patient population is. I don't know Scottsdale so well, but we have a lot of seniors, a lot of snowbirds that come from the north for 6-8 months out of the year, that kind of thing. So they're older. So the lady's in her 90s calls, says, do you treat kids? And we say, no, we don't treat kids. Well, she wanted to send her son. So we said, yeah, we'll definitely treat your son. He's 75, and we'll take his son too. He's 55. So it's all a matter of perspective. So I have found that the orthodontist is pretty well versed. I don't know how well they equilibrate, because they don't understand what I just explained to you. And it's not for them, their deficiency, but it's not published. And now it's pending publication. So I could freely speak. Like, I wanted to share this with Dr. Dawson several years ago, and I asked him to sign a non-disclosure because he was writing his latest edition of his book. And he definitely would have found this intriguing. And
Did he sign the NDA?
No, he wouldn't sign the NDA. So I said, well, I'm sorry, at this time I don't feel comfortable to share this with you. And now that his book is written, now that it's pending publication, he can take it. And
is it a new edition of an older book, or is it a new book?
Yeah, I think it's in his. The latest was like 8-9 years ago. He published his second or third edition of his book, right? And
so this will be his fourth one's coming out.
No, it's finished.
Oh, okay,
Yeah, it's out.
Okay.
Yeah. So I don't really follow Kois. I don't really follow Spear. They're awesome. I have a dentist in my office was classmates with John Kois at University of Pennsylvania, and thinks the world of him. And I've heard Dr. Kois lecture. I think the world of him. I think he's an awesome guy. And I think you can get, like mom and dad would always say, you take the good and leave the bad. Whatever camp you listen to, there's going to be some good. I think there's going to be some stuff that's maybe off the mark based on what I just explained, and you just sift through and get rid of the bad. Doesn't mean it's all bad. Doesn't mean it's all good, but it's expensive.
Well, you know how you said, that happiness is a big, important part. Of all the occlusal camps for everything, I think Kois has the charisma, the charm, the motivation, the happiness. He's just he's the most lovable guy. nobody meets Coyce and doesn't want a bear hug and go to dinner, and a lot of dentists, I think, don't even need all the technical stuff as so much as they just need motivation and leadership and charisma and love, and
this is a perfect segue if I can interrupt a second. My first day at Boston University, this is the story I referred to in the beginning. My first day at Boston University, I didn't know anybody. I didn't know any students there. I didn't have any contacts. It's a very small cafeteria as opposed to New Jersey Dental School. It was a massive cafeteria because we had a couple of medical schools and nursing school, osteopathic school, and all that kind of stuff. It was huge. All right, so I'm there. I'm looking for a seat. There's no seat to be found. I see a hand go up. I'm looking. He's waving to me. I don't even know who he is. I go over and walk over. I say, "Can I help you?" He says, "Yeah, I'm one of your professors. I know you because we have pictures of the students. It's your first day. Welcome. Here's a seat. Just opened up. Sit down and join us." So I go and put my tray down. And as I put my tray down, it was a 4-top table. I look up, and sitting right across from me, it says on his name tag, Henry M. Goldman. It's Dr. Goldman, right? That's the name on the school. It's Dr. Goldman. So I look up and say, "Oh my God." I said, "Hi, Dr. Goldman. I'm Steve Feit." So he says, "I'm going to do something that I find reprehensible, but I'm going to do it to make a point if you can forgive me before I do it." And I say, "Sure, sir. What is it?" And he holds his front finger out and he puts it towards me and he says, "My name is Henry. Please call me Henry." And with his other hand, he covers his finger to block it and put his finger back in. He says, "I apologize for pointing a finger at you. I did it for emphasis." So out of nervousness, I said, "Oh, that's okay, Dr. Goldman, no worries." So he says, "It's Henry." I said, "Okay, Henry." With that, the other person who was sitting, who I forget who it was, he gets up and leaves. He said, "I have a patient I have to go attend to." So now I have my professor, me, first day student, and Henry Goldman, and an empty seat. And with that, we hear the garbage can rolling down the hallway. It's a little old man. He's bow-legged, probably in his late 70s. And Henry looks down the hallway and says, "Hey, Charlie, come on in here and take a load off." Just like that. So Charlie says, "Okay, Henry, I'm going to just put the can in the closet. I'll be right in." With that, Henry Goldman got up and went online, didn't cut line, went online and bought a grape soda. And how I remember it's grape is, it wasn't RC Cola, Coke, or Pepsi, or Sprite. It was grape soda, specific. He sets it on the table, sits down. Charlie comes and joins us, the janitor. I'm having lunch with Henry Goldman, the janitor, my professor, and me, a first day student. So later that afternoon, my professor comes up to me and says, "Hey, I've been looking for you all day. I knew you were in lecture. What did you think of lunch?" And I said, "Lunch was the most amazing experience I ever had." And he said, "What?" He wanted to know if I got it. I said, "You can judge how big a big man is by the way he treats his fellow man." And he said, "Well, you got it. You want to be a human being." When I lecture, if I put my title slide up, it would be third or fourth because I don't want it to be about me. I want it to be about the people I'm speaking with. I'm not lecturing. I want to share, impart, or teach. I don't want to lecture to anybody. No one wants to be lectured to. On my slide, it would say Stephen Feit, HB, and everyone starts muttering, "What's an HB? I got to get an HB. How do you get an HB?" So then I pointed out, HB stands for human being. Be a human being. Don't be a dentist. People say, "Oh, you're a dentist?" No. I'm Traci's husband. I'm my kid's father. I'm Steve. Please call me Steve. I'm trained as a dentist. That's it. It's not who I am. It's not my persona. I don't want to be a dentist. Be a human being. And I would tell you, your patients, when they call me, and I'm sure you're like this because you're a lovable guy, that your patient will call you Howard, right? They'll call me, "Is it okay I call you Steve?" I'm in. I love that. I don't need the title. The title doesn't define me. It doesn't make the man or lady. The lady or man makes the title, right? It's what it's all about. Just what you just started to say, the human being. Be a human being.
And out here, especially in America, people always talk about race. The only race is the human race.
Human race.
Get over. Okay, one more question. I know I'm in overtime. I'm stealing you, but the Greeks, Socrates, Plato, Aristotle, Ancois, he's Greek too, they said there was just greed and fear. The very beginning of the podcast, you mentioned lawsuits, and a lot of people cringe. They come out of school, they're afraid. They don't want to end up in court, and that you just scared them. Why do people get sued for occlusion? These cases that you're representing, and what advice could you give these kids so that they don't ever end up in trouble like that?
Well, first it starts with relationship building. It starts with establishing trust, and it starts with informed consent. I was listening to one of the podcasts where the fella from Australia was saying, well, the patient was told it's $1,800 for a crown, and they get to the front desk and it's $2,050 because there was a core that was added. And the patient wasn't informed in advance. Well, that's a disaster, right? They're going to tell everybody what a disaster it was. People want to be surprised in what's in their favor. They don't want to be surprised opposite. So create the proper forms and disclose everything before. Informed consent is huge, but it's not for medical legal, although it is. It's more for your patients being on the same page as you. A bad result is not malpractice. Substandard, below the standard of care is malpractice. And you can be below the standard of care and remedy it. Even if the patient knows about it, if they like you, they'll allow you that opportunity. So often I'll see in the chart, right before there was a request for records from an attorney, it'll say, Dr. Smith offered patient all monies back. Patient declined. Okay, now they're suing because they hate you. They want a pound of flesh. It transcends the money. Or they go to the board. When they go to the board, they really dislike you because now they want to go after your ability to make a living. And they're coming hard. That's serious stuff. So I was an expert witness for the state board for about 6 years. So I know the mindset. If you get brought up in front of your state board, they have what's called experts. And an expert is no different. I was probably 30 years old when I was an expert. Now, I did have prosthodontic training, and the cases I would review were prosthetically related. But still, I didn't have 25, 30 years behind me as an expert might want to. So every time I got a case, I would see, oh, there really isn't anything wrong. And I would say that there's no probable cause. Summary result, dismiss case. I always looked for how I could get the dentist out. Now, ethics always prevailed. I always did the right thing. As you tell your kids, you're never wrong when you do the right thing, right? So if there was rationale, I would dismiss. So I didn't find enough probable cause in enough cases that they kicked me out as an expert. How about that, Howard? The ugly.
Now, was that down in Florida or up in New Jersey?
In Florida. I am licensed in Jersey. I'm licensed in Massachusetts, New Jersey, New York, Florida, and Arizona. I'm actually licensed here.
Really? Is there a chance you might work out here someday?
If you're hiring, Howard, anything can happen, Well, we had the hurricanes come through in 2006, and I physically could not get to my office for 2 weeks because so many trees were down in the road. In Boca. They couldn't cut them up fast enough to open the roads to get to the office. And my wife, being from Chicago in the cold and hates the cold, she says, there's no way I'm going to Massachusetts, New York, or New Jersey, so you better get your license in Arizona. So I was able to do that in the 2-week time because they allowed my state board, they gave me reciprocity, but I had to take the jurisprudence. So they sent it to Florida Atlantic University Testing Center because I had to do it without cheating, so that they can verify. And I got my license. So my wife is actually a Sun Devil. She went to ASU right here around the corner. So
that's where I got my MBA.
Yeah.
Huh. Well, so my homies they can look forward to some CE courses from you.
Oh, absolutely. I'd be happy to share my contact information if anyone's find themselves in trouble. It's a terrible emotional upset if you get a lawyer's letter. Doesn't mean you're wrong. Doesn't mean you're a bad person or a bad dentist. You're free to call me. I'm going to give you my cell number and my email. I'd prefer you call my cell and not the office because I don't have 15 in staff and that kind of thing. So we want to focus on our clients. My cell phone number is 561-350-0335.
Okay, one more time.
561-350-0335.
And your website?
Website is smilesspecialist.com.
Smile Specialist?
Yeah, singular at specialist.com.
Okay.
And we
you have another website, because don't you have your own name website, Stephen Feit?
yeah, there's a couple. I think stephenfeit.com, and then there's
Smile Specialist, easier to spell.
It's easier, yeah.
Any other and your email would be?
The email is quadbalance, QUADBALANCE @gmail.com. So we got 4 kids. I'm trying to balance my life with the 4 kids.
Okay, one last overtime. I can't believe I give you 30 minutes over. One last thing I have to ask, and that is, we think 20% of our podcasters are still in school. And one of the biggest questions when they get to the end is, should I specialize? What would you say to some kid if they're out there screaming, what do you think if I should become a prosthodontist? What would you say to that kid?
I'd say it's wonderful training, great background. I would do it again in a heartbeat. One of the reasons I specialized was I was looking to associate with my family dentist when I was a kid, and he all of a sudden he wasn't really ready to bring in somebody, so he said, look, why don't you get your additional training, and then when you come in you can understand what I'm doing and how I'm doing it and support me and cover emergencies. So of course, then when I got out of school, he still wasn't ready. I was an associate somewhere else for a year, as is typical. They promise one thing and they shift gears. So I helped build the practice up in a year, and then he wanted X dollars more for the work that I already brought in, that I already got him compensated for. And I just left and went from Red Bank, New Jersey to Florida, open my own practice. I would recommend it. Look, more training is going to give you that much more tools in your toolbox. I think I don't place implants. I've taken all the courses. I have a very dear buddy who we've been working together for about 27 years. He was down the road. His landlord gave him a hard time. I said, come in with me. I just moved to a bigger office because my landlord had given me a hard time, so I bought a condo. I said, I have an extra chair, see how it works out, and then you could decide where you want to go. And a month became 2, 3, 4. A year became 2, 3, 4. Now we're in our 5th or 6th year, and it's never been better. At the time of surgery, we're doing all on.
Is he a periodontist or an oral surgeon?
He's a periodontist.
And he does all on 4s.
Yeah, we do it together. Yeah, his name's Jack Krauser, Krauser.
Oh, yeah.
You know Jack.
Yeah.
Jack's pretty well.
Yeah, I didn't know he was. You guys practice together.
Yeah, now
I just thought you were friends. And all.
No, yeah, both. We have separate practices, separate staff, separate payrolls. We share the same address. He sublets because I'm the owner of the condo, but I call it our office. For vicarious liability purposes, we keep everything separate. It's very clearly denoted as separate. But at the time of surgery, he understands that I'm dictating the occlusal scheme. Therefore, I'm dictating the depth, the angle, the pitch of that implant. So as he's doing his pilot hole, he'll have me check it. I'm always making him guides and things like this. He's very clear to understand the survival of his beautifully placed implant is totally dependent upon what sits on top of it. And if he violates at his level, I'm not gonna violate at mine. So he's gonna need to try to find it out. Like, we're very clear on what we're doing, which never has a problem. So the planning is very exquisite. So he and I are speaking a lot. We're going to speak in San Diego in a little bit at the ICOI, and he'll speak. I'll lay the foundation of the occlusal pattern, and then he'll speak to how it relates surgically, which is such a unique twist. And with a team approach, this is truly a team. And we truly like each other. Like, the energy is truly there. He has given me a new lease on life, as they say. Like, he's really energized me. Intellectually, we're doing things that we could never do before. We do have a CBCT. I never had a CBCT because I always would refer to, that's how I was trained, was as a team approach. I like the team approach. If something goes south, I have a team to endure that, and we can work together. I know most people are, the dental students coming out today are placing 20, 25 implants in their training. That's awesome. If I was going through school now, I'd probably be doing all my own implants as well. But if you don't, it's one thing to create an osteotomy and stick in a thing of metal. It's another thing to understand, like if you pull a molar, do you want that implant in the mesial root or distal root? Well, let's talk leverage. Well, if the higher leverage is more distal, why don't you, if you have to put it somewhere, put it more distal to the midline, to the middle, because now you're gonna really sustain the forces, and you're gonna have less of a cantilever off that distal, right? So now it starts to take on another chapter, and that's a whole nother section of what we can discuss, and on and on and on. Now Krauser understands all.
Well, you got to get Krauser to build us some courses too.
Yeah.
And I'm so proud of those courses, because my whole motto is do everything better, faster, easier, cheaper.
Yeah, I'm in the process now of calculating if you at X dollars an hour, if you were to say every hour you're going to spend 10 minutes adjusting occlusion of whatever restoration you're imparting into the mouth, times how many days, how much money would you, in lost wages, would it be in income in a X number of year career? Staggering. So if we understand how to set things up, I didn't once tell you to buy an articulator. I didn't tell you to buy one piece of equipment. You could do everything with what you already have. I'm not selling. People don't want to be sold. People want to buy. I'm just explaining. And if you want to put it to the test, if you want to say where are the studies, well, why don't you look at the prettiest smile, have the person smile, and measure to the incisal edge. Is it 6 to 9 millimeters? All the time, every time. Check it out. And then also check out people who are in their 50s and 60s who have great periodontium. How's the plane of occlusion? Does it go to retromolar pad? Do they have interferences? You'll find that it follows these criteria. And then we can get into the T-scan, and I've done studies on altering occlusion on dentures, implant restorations as studies to try to evaluate. And the T-scan is the only thing that can quantify things. But there's inherent issues with the T-scan that you have to be aware of, and that's not what I came here to discuss today. We can talk another time.
Well, I look forward to seeing your courses, and I'm sure these honeys, you're talking to people in 146 countries right now, and a lot of them, they tell me when I'm in Ethiopia, Sudan, Tanzania. Ryan and I were just in Soweto, Johannesburg. It would be 3 months' income for them to fly to San Diego to see your course.
Right.
And they just love the fact that on their Samsung or their iPhone, they can, and then they just say it's just unbelievable that they can watch the Americans on their Samsung.
Yeah.
And it's just so darn cool. And I think this is, that's why I love podcasts, because they're just better, faster, easier, cheaper.
Well, look.
I can't believe I just delivered Stephen Feit to 146 countries.
Well, I listened to a bunch of podcasts before I came because I'm over 30, so I never have.
Yeah.
It was the first podcast I ever listened to because I'm just not familiar with the technology. And so I had a 4-hour flight and listened to 3 or 4 of them, and was fascinated. And so as my friend Fletcher down in Australia would say, I'm going to say this. Thank you, Howard, for the opportunity for me to come here, number one. Number two, it's always great to be in your company. I pick up your energy, which is awesome, and that's true. And if you weren't a happy person, I would decline graciously, but I would have never come. And what you're doing for the profession is absolutely awesome, because to create a community that you've done, to bring the level, to make collegiality the base of everything. Because I'm in the world of this litigation where the one colleague is against the other. The subsequent treater is saying negative things about the previous treater, which triggers the action. It's the complete antithesis of what it is. And Fletcher down in Australia, who's a buddy of mine, he worked with Patty Lund and the care nursing system and all this other stuff. He's been a good friend and a mentor to me as well. And in Australia, they would say, after I give you all those compliments, I would say to you, I'm not pissing in your pocket. And what that means is that you're getting a warm feeling, but for all the wrong reasons, right? So I truly say it from the heart.
Yeah, I would love to have Patty Lund on. I think I first heard him in the 90s.
Yeah.
He's been around a long time.
Well, yeah, Omer Reed was an influence for him back in the day. Omer did that front desklessness,
right,
and all that, and he's here in Phoenix, actually.
Right.
Yeah.
We've been trying to get Omar over here, but okay. Well, thanks you so much. I got to run, and you got to run, and all right, Kyle. Thanks for coming over.
Nice to meet you.
Love your Jordan shirt.